and today we're going to look at the prevalence of diabetic retinopathy in healthcare settings, determining whether this may be an early warning sign. And joining me for the discussion is Dr. David Rhine. Dr. Rhine is a senior fellow with NORC. Previously, this was the National Opinion Research Center. NORC is at the University of Chicago. And in fact, Dr. Rhine has been involved in an invited commentary with one of his co-authors on looking at longitudinal trends and disparities in diabetic retinopathy within an aggregated health network that was published recently by Dr. Jonathan Markle and colleagues in JAMA Ophthalmology. Dr. Rhine, thank you so much for joining us today.
It's my pleasure, Dr. Bressler. Happy to be here.
What was the bottom line that Dr. Markle and his colleagues found in terms of the longitudinal trends and disparities in diabetic retinopathy within their healthcare network? I believe this was the TriNet X healthcare network.
Yeah, so the bottom line is the authors report an increase in diagnosed prevalence of diabetic retinopathy among people with both type 1 and type 2 diabetes, as observed between 2015 and 2022. Most of this increase is coming from increases among patients in younger age groups, with the 20 to 39-year-olds having the largest increases, and then those increases declining as patients grow older. Another important finding was a higher risk of diabetic retinopathy among racial and ethnic minorities as compared to people who are non-Hispanic whites, with Hispanic people having the highest risk of diabetic retinopathy, followed by Black people.
Well, maybe you could tell me, and one reason we reached out to you for a commentary was this is very alarming. And is this consistent with perhaps what you and your colleagues have seen when looking at other databases, perhaps population-based data from the CDC or from NHANES, the National Health and Nutrition Examination Survey? How do those results compare with what this aggregated healthcare network is reporting?
So I think it's important to discuss the differences between a data source like, for example, NHANES, the National Health and Nutrition Examination Survey, and administrative records like electronic health records that they used in this analysis or that are used in the IRIS registry, or information that you can get from payment claims data like those that you can use to analyze Medicare or Medicaid or other insurance data. So NHANES is a population representative survey of community dwelling adults. And because of that, it includes people who visit the doctors as well as those who don't. Given this high level of population representativeness and lack of confounding, NHANES remains the gold standard for estimating national prevalence of many of the conditions that the survey examines. The problem that we have is that vision examination data have not been measured by NHANES since 2008, which leaves us with a lot of questions about what's happening in terms of changes in the prevalence of many of the eye conditions that we're interested in. And that's where studies like this come in. Electronic health record information and insurance payment claim information can give us information about how eye diseases are recognized in clinical settings among people who visit providers with the capacity to diagnose their eye conditions. Usually in the case of diabetic retinopathy, we're talking about ophthalmologists, but not always. And if you assume that people who are having problems with their vision are more likely to visit an eye care provider, then it also seems reasonable to assume that trends in electronic health record diagnoses and administrative claims may be able to tell us something about changes in the eye health of the overall population. But you just need to be careful because this is a large assumption.
So if these groups of people are not exactly the same, we may not see the same trends, but what sort of trends have we seen in either the CDC evaluations of diabetic retinopathy or with NHANES? Is it increasing there as well?
Well, let's say what NHANES can say. So NHANES data that was published in JAMA in 2021 indicate that the overall prevalence of diabetes, which is a necessary condition, obviously, for diabetic retinopathy, increased from 9.8% in 1999-2000 to 14.3% in 2017-2018. Other evidence, also published in 2021 in New England Journal, from NHANES indicate that glycemic control among people with diabetes has declined from about 57.4% of people with diabetes in 2007 to 2010 to only 50.5% in 2015 to 2018. So these two studies don't tell us anything specifically about DR, but they do suggest that the health conditions we'd expect to see if we were experiencing higher DR, for example, more people with diabetes, less glycemic control, are in place to support higher rates of diabetic retinopathy.
So that makes sense, but how about those people actually having diabetic retinopathy?
Right. So then we get to this question about what do other claims in EHR systems tell us about rates of diagnosed diabetic retinopathy? Because we really don't have other great evidence from population representative studies at the moment. So I'd like to note two papers in JAMA O led by Elizabeth Lundeen from CDC and including authors from the Vision and Eye Health Surveillance System, including myself. The first looked at payment claims for private insurance patients ages 18 to 64, and the second looked at payment claims for patients ages 65 and older who are enrolled in Medicare Part B. And both of these studies also found increases between 2009 and 2018 in the percentage of people who had diabetes who had at least one service coded with a diagnosis code for diabetic macular edema, other vision-threatening diabetic retinopathy, or DME and vision-threatening diabetic retinopathy at the same time. And both also found very substantial increases in the use of anti-VEGF treatment for these patients and decreases in other pre-anti-VEGF treatments. Looking across the Vision Eye Health Surveillance System data sources, we can look at time trends in Medicare, as Lundeen did, and also in Medicaid. And both of them show a similar pattern, which is that there's some evidence of increases in diagnoses for more severe stages of diabetic retinopathy, but there's little to no evidence of large changes, at least, in the prevalence of less serious non-proliferative stages of diabetic retinopathy, which don't threaten vision.
And do you think any of this is related to better imaging to detect conditions that might need more intense follow-up or might need interventions? We now have OCT imaging of the macula that's exquisitely sensitive at picking up macular edema. We now have ultra-wide field retinal imaging that even in an undilated pupil can sometimes detect moderate or severe non-proliferative retinopathy that might otherwise perhaps have appeared relatively normal to just a quick indirect ophthalmoscopic exam or even a direct ophthalmoscopic exam.
Yeah, I think that's exactly right, Neil, and a very good point. Our ability to detect diabetic retinopathy has improved immensely over the last 10 to 15 years. And greater detection and recognition of more advanced stages of diabetic retinopathy than we had in the past may be driving some of these changes in diagnoses. So the proliferation and improvements in OCT means that diabetic retinopathy is easier to detect in the past, especially but not limited to macular edema. And if this is what's driving the increase, then the implication could be that the rates are stable. We're just much better at detecting disease now, which is a great thing. And interestingly, in the Medicare and private insurance claims data papers, some of the largest increases observed in the diagnosis rates were increases in diagnosis rates of diabetic macular edema, which would be consistent with the theory of better detection ability.
Another thing that might make us at least question the numbers that we're getting are the accuracy of the health claims diagnosis that's put down on the electronic medical record and what the person actually has. For example, someone might obtain an OCT because they were suspicious that there might be edema from diabetes, and it's some unusual process and they're not quite sure how to code it. So they just put diabetic macular edema. Do we have a way of knowing from these large databases how accurate that is to represent the disease that indeed is being checked off on the box?
So I'm glad that you brought that up because in another paper our group published, led by John Wittenborn, we looked at the accuracy of diagnosis codes for detecting diabetic retinopathy specifically and other eye conditions as well, as compared to chart review text notes that were found in the medical records. And what we found is that the diagnosis codes are very consistent, at least with what is noted in the clinical record. So I think that this is a case of things being coded correctly, or at least consistent with the ophthalmologist or eye care provider's perceptions of what they're seeing in the images. One point to make would be before the introduction of anti-VEGF treatment for diabetic retinopathy, the treatments were less effective and less widely used. So there could also be a motivation to both detect more diabetic eye disease as well as code it, because now there's better options for treatment available to ophthalmologists.
Now, finally, when you say something like maybe around 10% had a certain diabetic retinopathy prevalence and it may be up to 15%, that's a 50% increase. And I know that ophthalmologists are already terribly busy in their practices managing people with diabetic retinopathy. Are we in need of further surveys to see if this is rapidly increasing? Because that might affect our approach to what sort of person power we need to be able to manage this potential increase in retinopathy that does have very good treatments, but are very intensive in terms of resources and visits and agents used to treat these at this time. What do you think is needed to see if we're already leveled out, or is this the beginning of something rapidly increasing?
Well, the number one thing I would love to see would be a new wave of NHANES data, which includes both retinal images and then also OCT, to be able to really see what's going on in the population as a whole, not just those who are seeking healthcare. Hopefully, we'll have those data in the future, which will give us very strong information about eye conditions in the general population.
I agree with you. I think that will be so important because even the analyses of these that used to depend on only experienced human beings looking at these images now may also be supplemented by artificial intelligence algorithms looking at these images that are obtained. So I think there's a strong reason to lobby for such images to help us in the public health of these major problems like diabetic retinopathy as well.
And I think you make a good point in terms of our ability to interpret the new images compared to the information contained in older versions of NHANES before some of this technology was available.
Well, I really want to thank you so much. We've been speaking with Dr. David Rhine, who is a senior fellow with NORC at the University of Chicago, on some of the increasing prevalences of diabetic retinopathy that are noted in numerous healthcare settings, and wondering if this is an early warning sign of more increases yet to come. So, David, thank you so much for sharing your knowledge, your experience, and even your work, not only in commenting on the article that generated this discussion, but also with your investigations on many population-based studies that are being done in the United States and helping people with diabetic retinopathy around the world. David, thank you so much.